No.
Hey, Justin.
Hey, how are you?
Good. How's it going today?
It's going pretty good. Just another day trying to do it. How about you?
Yeah, right. Yeah, I feel the same way. Yep.
Let's see.
I think Ashley said she might be a few minutes late, and Sophie was having wasn't feeling well. So,
I can imagine.
yeah, not fun.
I don't know if I want any more kids. I think I do, but at the same time, right now,
Uh,
I don't think we do because we're
yeah.
not sleeping. But, I think that
Oh,
changes when they get a little bit bigger.
that's true. How old's your little girl now? How old is she?
She turned 9 months yesterday.
My God, it's going so fast.
Life
Wow.
goes so fast, it's crazy.
It does. It does. Oh yeah, yeah. No, I hear you. I have one. I mean, I was team one and done.
Yeah.
Yeah, well, I started too late. I was 39 when I had my daughter, so yeah, it
How
was
old's
kind
your daughter?
she's 10 now.
Okay, yeah, that's a
Oh,
fun age.
yeah.
My son's 6. They're, a lot of personality and
Yeah.
independence, and those things
Oh
make it
yeah.
fun.
Oh yeah. Yeah. No, it's cool. It's cool now. You can have like full-blown conversations and there's such an opinion about everything.
About everything. Yeah,
Oh yeah, yeah.
it's
It's fun though. Little humans, right?
yeah, yeah, and I think just being able to have those conversations with them and kind of sets them up for being an adult and be able to have normal conversations. So it's good to entertain that.
Yeah, yeah. It's a crazy time to be a parent, though, I have to say, right? Like the world is, I don't know, it's a lot
Yeah.
of crazy stuff going on, just technology and just, I don't know, just the availability of information. It's a lot, right?
Yeah, I don't really know. My son, he'll get online and look at stuff like on my phone, and I'm just like,
Mhm.
it's crazy. Encyclopedia was like the way we look things up in, late
Yeah.
90s. So it's crazy to see the progression.
Yeah, yeah, that's what I feel. Same.
All right, I think we got Charlotte, and then we have about 6 ladies. I'm gonna talk about PCOS today, and then I have a set of labs with someone who had some like just typical PCOS like markers. So I figured kind of explaining that to clients. Let's see. I wanted to pause this for a second. Go. All right, I'm gonna bring everyone in. Lisa, I don't know which Lisa's note taker's in here, but I'm gonna remove you. Put in waiting room. I have this transcribed. Hello, everybody. Hope everybody is doing well today. Thank you for joining the Hormone Happy Hour. And today, just as we go over different topics, I was going to talk a little bit about PCOS and correlate that with some labs with a client I worked with who had PCOS. And but before I get into that, um, I see some familiar faces and then some newer names. Does anybody have any questions for us before we get too deep into talking about PCOS? That's fine too. No problem. Let's go ahead and come up in. I do not have as elaborate of a slide as I did last week, but this will work. So the reason I wanted to hit on PCOS. I feel like we talk a lot about estrogen detoxification and hormone balance, and I don't think I've done a full-on hormone happy hour on PCOS, and it's a pretty complex subject, and it can affect women not just in like the cystic ovary way, but there's several other manifestations of PCOS If you've been part of the program for a long time, you know I call it polycystic ovarian spectrum because there's a bunch of things that kind of fall in the lines of PCOS. So kind of getting into what it is. Polycystic ovarian syndrome. Sometimes there are cysts present. Sometimes you have all the other manifestations without cysts. I believe you need one of the four characteristics to get a diagnosis. If you're here, you've probably had a run around with your health, and it's not always about a diagnosis. A lot of times we're just looking at root causes, and if you're in a gray area, that so be it. But potentially figuring out ways and reasons why those things are happening. So, really, you want to think about it as a an interconnected piece. We talk about that a lot. It's not just a single system. I think a lot of times people will just focus on the ovary aspect. Brain ovary is a connection, and then your metabolism as well. Uh, 1 in 10 women are affected. Each person's pattern is unique depending on genetics, stress, and environment. I think Charlotte would probably agree with me. The environment piece can also really throw a wrench into things. So I think really acknowledging that piece, and that's something that we will spend a lot of time talking about as a collective. And common signs, some of the things I see probably stick out the most. And coaches, you feel free to chime in, but I'd say the abnormal menstrual cycle is something I see a lot with PCOS. Sometimes it's not acne or oily skin, or you may not have abnormal hair growth. Um, Other things that I do see accompany that is weight changes, and that could be potentially central adiposity, so weight gain around the middle, or just weight loss resistance. With some of the things that happen at the biology, your biological levels will cause some issues to happen with weight loss resistance and just that gain around the middle. But all of these are potentials, trouble sleeping, mood swings, fatigue, energy crashes, hair growth. I just call that abnormal hair growth. Anywhere you deem you shouldn't be growing hair, those are signs that your follicles are very sensitive and they're getting overexpressed to things like androgens. So, kind of getting into how hormones get out of sync, I would say, listed at the top, insulin resistance is something I see with a lot of both men and women. We service clients globally, and I would say the insulin inflammatory component is something that a lot of people struggle with. So that's something that testing and getting understanding if insulin is causing any of those issues. This specifically says high insulin can increase total testosterone in the ovaries. Your ovaries are intelligently designed to produce things like estrogens and androgens, and through different enzymes in the ovary, you will convert a lot of those androgens into estrogens through FSH. So we also test FSH. A lot of times when insulin's high, that can drive up LH signaling. So you could see that potentially in someone's labs if they are having a normal menstrual cycle. That's a caveat there. But, the testosterone increase at the ovaries happens. Excess testosterone can potentially block ovulation. As a piece of it, there's a lot of things that can inhibit ovulation. Low progesterone can also do that. Thyroid can also do that. But just acknowledging, the testosterone component is something that can cause some issues there. And so no ovulation, low progesterone, and potentially high estrogen. The high estrogen piece, if you've chimed or you've sat in several of these calls, you know that it's not always the ovaries producing estrogen. Could be an issue with recycling estrogen. You may have too much estrone, so there's a lot of things that go into that. We'll get into that with the set of labs that I have. And then inflammation is something that keeps that cycle stuck. So if we're looking, at that insulin resistance and creating hormonal imbalances and irregular cycles, looking at root causes. So inflammation could be a piece of that. It could be insulin. It could potentially be environmental. Those are other things that can play a role in this. So, um, looking at the like four patterns, I would say you have that insulin resistance component of PCOS, so blood sugar imbalances, sugar cravings, maybe fatigue, specifically fatigue after meals is something that I see. And then, weight gain around the midsection. Adrenal stress in PCOS. So your adrenal glands are going to make things like DHEA sulfate, and those can also, at high levels, cause increase of testosterone. Low cortisol can also drive up things with abnormalities around menstrual cycles. So anxiety, poor sleep, energy crashes. And the thing is, if you look at the adrenal piece and the insulin resistant piece, a lot of these things can mirror one another. And that's why looking at diagnostics is pretty helpful. Um, and I would say the post-pill PCOS it's something that I personally see a lot of is coming off of birth control, having irregularities with cycles. I would say that's not going to fall within like a classification of a medical diagnosis, but in functional medicine, that's something we see quite a bit. And I've worked with several women, and your cycle may not come back 30 days later, 60 days later. It may be 6 months, it could be a year. I think age also depends quite a bit on that. If you want more info on birth control, I think we did Hormone Happy Hour about 3 episodes ago where we went in depth and all of the interconnections of human birth control and potential dysregulations to your hormonal balance. And then the last piece is that inflammatory aspect. So your chronic immune activation, skin issues, bloating, joint pain, food sensitivities. I think GI is also going to play a role in this. So it's a manifestation of a lot of these things. I would say, why people tend to get not necessarily a diagnosis and people throw their hands up is because a lot of these things are interwoven and it's not just so black and white. I wish we could test and be like, oh, that's it. It's just this one thing. But a lot of times, a lot of these things overlap together. So, it's underlying causes and not a single treatment. Um, getting more into why insulin matters. So we talked a little bit about the testosterone aspect. The thing you'll see quite a bit if we look at like the abnormal hair growth, your body makes something called sex hormone binding globulin. Um, your sex hormones are very similar to cholesterol in structure. Cholesterol cannot move through blood because blood is like 80% water. So the sex hormone binding globulin will basically deliver hormones to appropriate places in the body. And it's made in the liver. And a lot of times, insulin resistance will downregulate sex hormone binding globulin. So even if you don't have an excess of testosterone, so you're within a normal range, but your SHBG is bottomed out, that potentially can cause some symptoms. The other component with SHBG and what this bullet point talks specifically about is increases free androgens. So with testosterone, you have something called dihydrotestosterone. It's a more potent metabolite of testosterone, and that's the reason why I have a mustache and I'm able to grow hair all over my body. Men tend to have quite a bit more of dihydrotestosterone. We also tend to have higher amounts of free androgens. So SHBG basically acts as a net and holds on to dihydrotestosterone. Women's sex hormone binding globulin reference range is much larger than males. And it's really a Goldilocks. Too high, it'll hold on to your free forms of hormones. Too low, your hormones don't have the appropriate delivery vehicle to get them to specific sites in the body. So, again, it's a lot about symphony and a balance of these hormones. These hormonal shifts can cause acne, hair growth, fatigue. So we talked a little bit about that. The things that I think a lot about are the supporting strategies. We could get into pharmacological aids, but I really like starting at the base level of things is like, I think simple things is eating a well-balanced diet. That's going to really help with regulating blood sugar. So proteins, fibers, fats, not grazing throughout the day. Um, what else with that? Walking throughout the day. Those things tend to be helpful. Limiting processed or refined sugars. Those things also seem to be helpful. And then sleep. I think sleep is like the unsung hero. If we can't get adequate sleep, and it's not just duration in bed, it's a quality of sleep. That's also going to cause issues with inflammatory signaling, blood sugar dysregulation. So your sleep, and then last, and Ashley would agree with me, is stress management if we want to regulate our blood sugar. Cortisol is a glucocorticoid, so it has direct impact on glucose uptake into the cell, so it definitely matters. So, kind of taking a broad stroke approach and looking at all of these areas are going to be extremely helpful. And next, getting into like stress in the adrenals. So, chronic stress, and it depends. It can potentially increase DHEA. A lot of times your cortisol will go up for a period of time, and then eventually your cortisol will bottom out, and you have just a flat cortisol response, which can drive on things like chronic fatigue. Cortisol is also anti-inflammatory, so we want to be mindful of getting our waking hormones to pulse at the right times and suppress at the right times. um, the other pieces is cortisol suppression. Our cortisol suppresses ovulation and insulin increases insulin resistance. We hit on that. Often seen in women taking care of a bunch of things, if that's work and that's children, that's all the things. I will say that you women are much better at multitasking than us men, and I will gladly give you that. My wife can bounce the baby on her hip and talk to me and do another thing, and I can't do one thing. I can only do one thing at a time. So definitely nurturing your body's ability to recover and rest and be in that parasympathetic or restful state is going to be very important. Supporting strategies with that, I'd say globally, if you're able to get sunlight, that is something that can be extremely helpful for you. If you've ever consulted with me and you're somewhere in the world where sun is more scarce, talk a lot about red light therapy or happy lamps. Those things are also great tools to help increase cortisol upon awakening. I would say that's probably like one of the easiest things to do to start to regulate your stress response. And that takes a long time, but it's something that we all should probably adapt or adopt and use. Structured recovery days. So if you're in the program, I'm sure your coach doesn't have you working out 7 days a week. I'm sure that there's scheduled rest days, active rest days, yoga, stuff like that. We do that not because we don't want you to work hard, but it's not all about going all the time. We really need to work on that recovery aspect. Um, and then, yeah, breathing exercises before bed. I think those things are great. I would say if you can just like get off your phone, get off your computer, and just relax, stare at a wall, whatever you like to do to decompress. Those things are extremely helpful. For me, it's really just putting my phone on do not disturb because the longer I'm on my phone in the evening, the worse my sleep is. So that is a huge piece for me. Um, let's see. Angela dropped a question in here about red light. Should we aim to use our red light in the morning? I always use mine at night. The red light therapy will help with cortisol awakening response. I do think red light therapy potentially has some application in the evening. I'd rather be exposed to red light therapy or red light versus uh, like heavy fluorescent lighting that's very bright. I think that you could use it in either application. There's a lot of different ways um, you could potentially use something like that. I use mine in the morning. quite a bit, and then I use like a blue light blocking red tint type of glasses in the evening. But there's application for both. It is anti-inflammatory. It does regulate cellular function. I would say that for me personally, I tend to get a little boost of energy when I use it, so I don't tend to use mine at night. I think there's context for each individual. So that would be something that I would say, Angela, play around with and see like, hey, does this help me relax and rest a bit more? Does this kind of increase my energy? I and it's right here. Have this PEMF mat because I love all the gizmos and gadgets. This one has red light built into it, and I will use some of the delta waves closer to bedtime without red light, and in the morning I'll do more gamma waves with red light, and that just seems to help wake me up. But I think that red light component is going to be based off of your biological response to that. So. I would play around with it and see where you notice improvements in energy, mental clarity. But there's lots of benefits to it. Um, let's see. So we hit on the supporting strategies. We hit on the breath work. Yeah, I think thyroid's also a big piece to look at. So thyroid hormone is something that I see because we get a lot of people in here who maybe work with a fertility specialist or have gone through IVF, and a lot of times they're always looking at getting the ovaries more efficient at making estrogen or making progesterone. But your thyroid's also going to have a big role in ovulation as well. So underactive thyroid will slow ovulation. Sometimes with PCOS, there is a high estrogen component to that. So I'm going to demonstrate, I'm going to show that on a set of labs today. So high estrogen raises thyroid binding proteins and potentially lowers free T3. This can mimic or worsen PCOS symptoms. So if you're watching this and you're like, hey, I have all the telltale symptoms of PCOS, but I can't get a diagnosis, it could be any of these things, or it could be a mixture of several of these things. Supporting strategies for thyroid, test your thyroid. What was not included in here is looking at your antibodies as well. I think that's the immune aspect is um, worthwhile and is notable specifically if we're looking at ovulation. And then making sure you're getting, basic nutrients for your thyroid, iodine, selenium, zinc, protein, tyrosine can fall in there. A lot of times with downregulation of thyroid, we also can see the adrenals playing a role in that. So all of these things could be potentially causal factors, and that's why testing is so helpful. And gut and inflammation. So this would be the piece that I hit on earlier is maybe the ovaries aren't producing a ton of estrogen. But dysbiotic bacteria in the gut may increase estrogen recirculation. Um, I would say that being able to look at a GI map probably helpful for everybody on this call. Something that I tend to look at. So I do all the blood work, but I'm going to tell on myself here. I always will look at the GI map as well because I get such a good idea of what's going on with the GI map, and then I can compare that to blood work. Specifically, like estrogen dominant like symptoms, we have some specific markers in there, beta glucuronidase. If we have any dysbiotic bacterias, sometimes you can do a zonulin add-on to see if you have any leaky gut, quote unquote leaky gut. All of those things are manifestations that show up in your blood work. So they are tied together. So we want to make sure that you're eliminating estrogens as well. Um, and I find that so interesting. I talk with so many people. I'm like, do you have a normal digestion? And they're like, yeah. And I'm like, well, do you use the restroom every day? And they're like, well, no. And I'm like, well, you don't have a normal digestion. Then like you should eliminate at least once a day. That should be like just basic rules of like normal normal bowel function. Um, so supporting the gut health will improve ovulation and hormone clearance, and a lot of the bacteria in the gut when it's overgrown creates lipopolysaccharides. That's just a fancy term for endotoxin. So it's just creating more inflammation, and it can exacerbate this. And I will say that allopathic medicine does not acknowledge that, and they don't really believe in dysbiotic bacteria. But we know, looking at the gut is going to set a stage for potential other inflammatory issues in the body. Supporting strategies there. Staying hydrated is probably like the one of the foundational pieces. I'd say having enough minerals and getting enough fluids. I like to give the analogy that if your sewage pipes don't have any fluid in there, nothing's gonna move. So you need enough water to kind of make everything flush out. So water, fiber. Ashley could probably go in much greater lengths of details of why fiber is important, but fiber is going to play a huge role here. It's going to help bind up various things. It's going to help with bile flow. It's going to support, you know, um, your gut lining. So I talk about this a lot, but I used to have a diet of like 5 grams of fiber a day, and I definitely paid for it. So fiber is something that I pay a lot of attention to. And then potential probiotic and prebiotic foods. I'm a big proponent of prebiotic foods, prebiotic fibers. Those things I tend to consume quite a bit. Ashley dropped in here, fiber supports short chain fatty acid production, ultimately butyrate. I believe that's good for the colon. There's a lot of benefits to fiber. And I believe if anybody's curious, you can go online and there's like several studies that ties like all-cause mortality to fiber intake. So it's like there's enough data out saying that fiber is important. Um, Not to step on the toes of anybody who doesn't consume fiber, maybe does like a carnivore-based diet, but in my opinion, I think fiber is very important. Um, let's see. Key labs, and this is very condensed. I could probably spend hours and hours talking about PCOS, but like key things to look at, fasting insulin and glucose. I would also have a hemoglobin A1C in there. I think that's important. So we can look at what your glucose looks like 12 hours without food, what your insulin looks like 12 hours without food, and then the 98-day average of your blood sugar. I'd also say triglycerides are going to fall within that as well. Um, Looking at DHEA, I think is helpful. Free and total testosterone. You could look at cortisol. I like to look at that more in a salivary or urinary sample, but you could pull it on blood, especially if you don't want to fork out a ton of cash for a specific test. I still think you can get some like okay data with that. You can make some assumptions of what your cortisol's doing. Getting into some of the sex hormones. If you have a cycle, a lot of women with PCOS are not going to have a cycle, but progesterone mid-luteal phase. So we always say, hey, days 19 through 21, if we can figure it out, that's going to show your progesterone surge. Um, That'll also give us an indication on your LH and FSH, and then your sex hormone binding globulin. You could lump testosterone in there. I think that would be helpful. I think looking at estrogens as well, and not just your estradiol, maybe your estrone, looking at your thyroid. I'm going to add thyroid antibodies in there, C-reactive protein, vitamin D. These are some of the pieces that I think are super helpful. And then we hit a lot on these foundational pieces. Strength training is going to be, I think, one of the best tools you can use to regulate your glucose and improve your metabolic health. Walking after meals. I think cardiovascular work is great. Meals, protein, healthy fats, fiber. I really try to combine all of those in my diet throughout the day. Stress management components. I really like the time outdoors piece if you're able to. I think that's great. Getting quality sleep is going to be extremely important. Colorful foods, hydration, daily bowel movements. Um, so what I wanted to show everybody is a set of labs that I did on a client's. Um, they're about a year old now. Um, let's see. Oh, boom. Okay. And she had been without menstrual cycle for a period of time and had a PCOS diagnosis. this testing has like all of the outer range summaries. Her alkaline phosphatase was really high, so some stress on the liver. Her C-reactive protein was really high. Her cortisol was extremely low. And we want to take that with like a grain of salt. The collection time was late in the afternoon, but still, even if we're looking at a PM sample, she's going to be on that lower percentile. So PM samples are going to be from 2.3 to 11.9. Sex hormone binding globulin was very low. She was having some acne and some, not any hair growth, but just a lot of hormonal acne. And then lipids were abnormal. So severe HDL suppression, increased LDL. But other things that may not always be highlighted when we look at the lab panel, I want to get in and show some of the hormone markers in regards to estrogen. So a lot of times people just look at an estradiol, and she had a 75. This is going to be more of an abstract of where she is. So she is in her luteal phase here. She's, lower percentile of normal. It's not clinical. But her estrone was, or her total estrogens were a 336. So she's expressing a lot of other estrogens through different areas that could probably be a lot of estrone, not as much estriol. So estrogen's going to express in fat tissue, so you'll see an upregulation there. I like to look at a homocysteine to get an idea of phase two estrogen metabolism. That looked pretty good. But if we're going to tie this up to another marker, because all this is interconnected, I'm going to come in and look at her alkaline phosphatase being extremely high. And I would segue this together saying the liver is probably inflamed and she's probably having issues metabolizing estrogen. So that was an area that we worked on. Pomegranate, dim, sulforaphane, those things were quite helpful for her. Um, what else stuck out here? A lot of GI issues. Um, so lower iron, lower ferritin. Her progesterone wasn't extremely abnormal. A lot of times with PCOS, I'll see this, in that luteal phase, less than one. So she was making some progesterone, but I would say that's not enough for a healthy ovulation. So lower amounts there. Um, Again, screening for thyroid and looking at her thyroid. Things weren't terrible. The TSH is suppressed. She could use some bumps in free T3. Free T4 looked okay. But we just want to cross these things off and make sure they're not abnormalities. Um, but what I would say is like this C-reactive protein being so high, she did have some low grade insulin resistance. So you might say, well, it's not clinical, it's not over range. 10 without food, once you can start consuming food, this is going to go up pretty significantly. And then we can kind of confirm with some insulin resistance with that sex hormone binding globulin. And other pieces, her hemoglobin A1C, that average blood sugar over 90 days, she's not clinical, but she's on the upper cusp of normal. So that was an area that we wanted to work on, is insulin resistance. Over the course of 6 months, I believe we were able to lose like 30 pounds, but that really having a plan of attack of working on these specific areas was super important. So yeah, understanding these specifically if you have PCOS or you know somebody with PCOS, getting adequate diagnostics done is going to be extremely helpful for you. And then working with somebody to be able to reverse engineer these processes. So I think that, uh, you know, more knowledge, the better. Everything is interconnected. I wanted to pause and see if anybody had any questions or if coaches, if you wanted to add anything. My Mac is on 1%, so I'm going to plug it in. I will be right back. Thank you all. Um, yeah, does anybody have any question pertaining to this lab work or their labs, any labs of their own? We'd be happy to spend some time, answer some questions for you. Um, yeah, I wanted to pause before we wrap up.
Justin, I have a client that has had lab work done, but she's not getting a reading. I didn't actually get confirmation to read it, but could we do that next week
Yeah, I'd love
to go
to.
over it?
We
Okay.
can redact it and look over it. What is going on with her?
There is definitely fatigue and poor sleep, high stress, but there's some definite markers on there that show why she may be fatigued. So, yeah, I think she'd be happy to be have it read. But again, I just want to wait till I get confirmation. I don't really have a question about the PCOS so much as the question that we talked about earlier for one of the participants here today. So, just what is your thoughts on testosterone converting to estradiol? Um, and then BP157 and Ipamorelin specifically for peptides.
Yeah. So the things I would think about with using bioidentical testosterone for increased estradiol production. Um, if you look on paper, yeah, I mean, it will aromatize. There's some like nuance with that. Not everybody aromatizes at a high rate. And then your dosing is really going to matter. So I'll give this analogy is if I take 200 milligrams of testosterone, I'm going to have a higher rate of aromatase. That's more milligrams. Men will tend to see more expression of aromatase to the our estradiol range is significantly lower. So 40 or 50 nanograms per deciliter for estrogen for me makes me very emotional and can cause a bunch of issues. For women, because estrogen is or was your primary driver for hormone production for some time, that aromatase expression you may get from, and we'll go on high end if someone's taking like 15 or 20 milligrams of injectable testosterone, you're not going to have a huge increase in aromatase expression into estrogen. What you could do if someone, say your practitioner doesn't want to change that for you, you could just track your FSH. So if you say your estradiol is we'll use hypothetical numbers, is 100, and your FSH is a 60, and then you increase your testosterone, and your estradiol goes up to 110, and your FSH goes to 58, it's probably not enough for you. So if you want to get an idea of what that looks like, you can just kind of catch those trends based off of your FSH. And what I mean by that is, let me see if I can get a picture. Everybody knows I love pictures. Um, let's go ovaries. And see if we can get this negative feedback loop to pop up. It's so we'll hone in on the female side. So when you go through your menstrual cycle and say you are menstruating, this FSH suppression, this will happen every month. You're going to have more months where this is going to suppress down when the ovaries are producing estrogen. It's going to send a negative feedback loop up to your brain saying, hey, ovaries, good job making estrogen. I don't need to increase this frequency. When you're in menopause, FSH gets really high because the brain is signaling to the ovary saying, hey, please make estrogen. There's none available. I'm going to increase this frequency as high as I can, trying to get your body to produce it. When you take estrogen from a pill or a cream or a patch, even though the ovary is not making it, the brain recognizes there's enough estrogen present. So FSH will actually suppress. When you look at labs, there is a legend for that, and it'll show you postmenopausal ranges. I believe this range starts at like 50 and goes up to 120. Really, you would want to have a suppression, I'd say closer to 20. You don't want to completely suppress it where it's like a 3 or 4. That may be too much estrogen for you, but you should see a subsequent decrease in FSH. That's your brain recognizing there's enough estrogen in the body. So I would say if you've increased your testosterone or you're hoping to get some aromatase activity, you may get a little bit. What I will tell you is I've read thousands of labs and I rarely see that be the case for women. I gave Charlotte this example earlier. Is I have a client, she has BRCA2 gene, she cannot take estrogen. She does take testosterone. Every time we check her estradiol sensitive, I'll run more sophisticated testing on her. Her estradiol is like a 7. So it's very, very low, and she's on I would say 7 milligrams of testosterone. So it's not a ton, but she does not get any aromatase activity. That may vary for this client. She may get more increase in aromatase activity, but it's probably not going to be enough to offset. Uh, my recommendation is probably adjusting estrogen dosing and if this individual has issues with clearing estrogens, it goes back to gut, intestines, liver. We want to work on those axes, get your body efficient moving your estrogens, and then potentially you can handle more estrogen. I hope that answers your question, Charlotte. Is that pretty clear? Okay. And then you had questions on like BPC 157, and was it Ipamorelin or Samorelin?
I think it's Ipamorelin.
Ipamorelin. So Ipamorelin is, I always get this mixed up. So you have growth hormone releasing hormones and you have growth hormone releasing peptides. Those are the two classifications that those drugs work off of. Ipamorelin will work, it works okay. So I would say that it can help with sleep to a degree. If you have a severe cortisol dysfunction, it's probably not something I would recommend initially for sleep. And I don't really recommend it for fat loss. I would say this peptide is probably going to be like more in the classification for somebody who already has great sleep, maybe has pretty good body composition, and then being able to utilize something like that may give you an extra 3%. And if you're already in great shape, that 3% will be noticeable. If somebody is, they're trying to work off 20 pounds, hypothetically, that 3% of 20s, you're really not going to notice it. And those peptides are super expensive. So like I would say um, probably not the one I would lean into unless somebody's really dialed in and not having any issues, but really wanting to use it to just get a little extra edge. I'd say athletic population tends to do really well with that. I would look at some of the other mitochondria-based peptides, specifically if it's for body composition. If you get your cells interacting faster, that's going to speed up metabolism, increase basal metabolic rate. There's several of those mitochondria-based peptides. We actually did a hormone happy hour last week on that, so that would be something to forward and let them watch. There's a bunch of cool stuff that you could use in place of that. And then BPC is something that I've talked about and had several people here in this program use it. I use it pretty regularly. BPC 157 oral is going to do a really good job of reducing systemic inflammation. I like it for chronic inflammation, autoimmunity, GI issues. It increases nitric oxide. It's going to have a lot of benefits for the body. There is no toxic dose with BPC either. I have a client in this program who goes and flies to Mexico and she does stem cells and they IV her with BPC. So if you're able to IV BPC, taking it orally is very, very safe. There's not a toxic dose of it. Now the injectable, there's some like more like nuanced reasons I would use that. If you have say you just tore a ligament or tendon, it's going to have a lot of utility of speeding up blood supply to ligaments and tendons. My father-in-law, he is 61. He loves to do jujitsu, and he tore his bicep off the bone. And as you age, you don't heal as well. And we use BPC for like 12 weeks, and he had like full range of motion when he went to his or his last post-op visit. So they cleared him. They're like, I don't know what you're doing, but just keep doing it. And they're like, I've never seen anybody your age heal this quick. And yeah, he's back to do that was earlier this year. He's back 100%. I actually coach him, and he sent me videos of him doing pull-ups the other day. So, his bicep is back intact. That would probably be the peptide. I'd say it's universally beneficial for most people. I would say there's really not going to be any negatives to it. Um, what about for nerve issues? Yeah, so there is some data supporting nerve function. The other one that someone could look at is NAD plus. Both of those seem to work well for nerve. Um, I would say if someone's dealing with neuropathy, locally to the site is probably going to be best places to put BPC. Um, I know that could be painful. Worked with people who have neuropathy in the feet or hands, but using that BPC closer to the site will help rejuvenate nerve endings. BPC is great. Um, NAD also has some application. Um, what else was I going to add with BPC? Great for liver inflammation, kidney fibrosis. There's a bunch of research supporting all of those things. The FDA keeps on pulling BPC from us. There is a new formation of it. It's called pentadeca-arginate, and it's basically BPC. They just kind of changed the structure of it. But we get that from compounding pharmacies. You can get the oral but the injectable has changed format. So I would say I would spend my money using BPC over Ipamorelin any day. I would double up on my BPC versus taking Ipamorelin. Uh, Holly, yeah, there is injectable format available through First Optimal Telehealth Company. We have had several of our clients get onboarded and become patients there and be able to get access to that. So that would be something to consider. Um, yeah. Uh, any other questions from clients, coaches? Okay, look, we got another one. Normal TSH, free T4 or free T3 and free T4. And I suspect there's probably low normal TSH, free T4, free T3. And I suspect there is a problem at the pituitary gland. I mean, potentially. You know, I would say other pieces to consider. Just because your TSH is suppressed and looks normal doesn't mean your thyroid gland's actually making enough like raw material like T4 and T3. Um, there is, and I've shared this before, but I'm going to drop it in here. I like this study. See if it'll load. Bear with me. And this is from one of my favorite doctors. He's a pioneer in the anti-aging space. Mm, where is this? I have a million studies in here, so bear with me. It could be that, Angela. The other thing I would consider is your reverse T3 and then your cortisol. And Dr. Ken Holtorf is the author on this. I'm going to drop this in the chat. Oh, where did it go? Boom. There we go. So anybody on a computer should be able to download that. That's a great piece to share with clients or just for clients themselves. But um, a lot of times this will talk about normal ranges of thyroid. And a lot of times you may have suppression in TSH, but free forms of thyroid may decline, free forms of T3 may decline. Reverse T3 is something that tends to drive up in a lot of people. And this can be from a lot of things. So yeah, normal aging, I'd say your thyroid is just like your ovaries. It's going to quit working as well. Um, Diminished tissue levels of T3. You may not be getting enough into the cell. Um, uh, Severity of illness, depression, calorie reduction. So I think a lot about um, things causing like stress, depression, cholesterol levels, insulin resistance, chronic dieting. These are things that is going to drive up your reverse T3 and decrease your T3 and T4. So this would be worthwhile reading. This goes in depth and we'll talk specifically on reverse T3 and how T4 is a poor choice of treatment. That's just my personal opinion. I don't see that really working that well for people. Sex hormone binding globulin, I hit on that earlier. That's also another piece to consider. But yeah, I would look at this and get some assumptions. So how do you assess thyroid function when you're on T3 only? Well, I would say that's a great question, Angela. I would start with if someone has you, and I'm not going to talk in absolute, say you are on T3 and your T4 and TSH, say your TSH is within normal range and you're still making some T4 from that gland, I would assess mainly off of a T3 and symptoms. Does somebody have less fatigue? Are they able to start to move and lose some body fat and seeing improvements in digestive function? As soon as somebody starts to have downregulation of T4, which can happen in some individuals, and TSH increases, that's probably when I would do a dual therapy. A lot of times, people will tend to have negative reactions to T4. I tend to see that sometimes. It's going to be very circumstantial on what that individual needs, and that's where testing comes into play. So I'll use you as hypothetically. Say you're on T3, we do a set of labs, it looks really good. We do follow-up labs, and then your TSH goes from like a 2 to like a 4, and then your free T4 drops below range. Really, I would probably want to implement like a combination thyroid medicine at that point just to take pressure off the pituitary so you're not signaling as much that TSH. That I think would tend to be like best case scenario, but I think it depends on your biology. If you're making enough T4, you may just need some additional T3. I see that from person to person. Um, Okay, so Andrea, at the same time, prolactin is high, getting prolactin, prolactin retested. Yeah, prolactinomas are another thing, and I could just go forever on this, so bear with me. Um, let's go TSH and prolactin and TRH. So. You may often see this as well. I would pull like an actual data on this, like an actual study. Actually, you could download the PDF. So, hyperprolactinemia associated with subclinical hypothyroidism. It's common. Not overly common, but prolactinomas are they're out there. Just no one ever tests your prolactin. So even if your prolactin is normal, looking at thyroid releasing hormone would be helpful for you, and then that macroprolactin number would also be helpful. But I've seen people use Dosinex or Cabergoline. It's what type of medication is that? It's a dopamine agonist, and that actually will lower your prolactin and put your numbers within range. Hyperprolactinemia is also a big driver of infertility and inovulation. So I would look and rule that out. But that potentially could be causing some issues with your thyroid function. They're all interconnected, and prolactin suppresses ovulation because when we lived in caves, our prolactin was high when women were breastfeeding, and you were not supposed to be able to reproduce at that time because you're getting chased by bears and you have to go salvage your food from the jungle. So you're not supposed to be able to have babies at that time. So prolactin will disrupt all of your endocrine function. So I would definitely look at that. Um, can't do the TRH level. My PCP can't do the TRH level. My PCP said today. Yeah, thyroid releasing hormone, it may just be the type of equipment that laboratory has. I know you're in a different country. The reason I say that TRH is something someone could look at is I have a catalog where I can pull pretty much any lab. We all of us coaches do. We could go in and look, and it's just probably your specific area globally where you may not have the technology to do something like that. Um, and Angela, my TSH has increased since starting T3 only therapy, feeling way better, but it would freak prescribers out. Yeah, I think that T3 therapy, um, tends to work really well. Anybody who looked at that document, Dr. Ken Oltorf had Lyme. He was like a pioneer in using T3 therapies. There's something called the STARD study as well, STARRD. They compared T3 therapies against antidepressants. T3 is an essential hormone. If you can't make it, you should replace it. All right, I've been talking very long today. Thank you, everybody, for joining. It was great seeing all of you. And if you have any questions, bring them next time. And we'll see you next week. Bye.